for a consultation when I shouldn't have to do that. So the classroom doesn't translate well to the realities of the bedside, and perfectly honestly, it has not been my impression as I see these young people on the wards or the people teaching them that what we have attempted to gradually soak into their psyches has stayed there. It has dried up in the excitement of the new liquid in which they've submerged themselves, the liquid of salvaging a life, because that's what it's all about. It's all about cure, and it isn't about care, and those are two very, very different things. So we have the fact that the classes have to be in the first and second year because the kids don't have time to come off the wards and sit down and talk about Tolstoy. They just can't do it, or talk about ethics. What about the great influence of the hospice movement and the palliative care movement? In 2010, when I finished my survey, and just before that last chapter was published in the new edition of How We Die, there were 1,300 men and women who had passed their specialty boards in palliative care. 1,300 people. You know how many dermatologists there are? 8,500. It's a shocking figure. There are 700,000 doctors in America, and of those, only 1,300 are boarded in palliative care. Statistically, there is one for every 3 hospices in this country. So many of the outpatient facilities for hospice are not in any way supervised or involved with physicians, except the patient's individual physicians, who may have different ways of looking at things, which actually I'll talk about in a moment. I talked about the fact that there is a Medicare provision for patients who go into hospice. Hospice, Medicare will pay for hospice care. But if you look at the law, it gets a little scary because there are certain provisions that come along with it. The physician must certify that the patient has less than 6 months to live. I don't know too many physicians who are willing to prognosticate that way, who are willing 6 months before death to say this person has less than 6 months to live. There's also this very difficult psychological problem of a patient going into a hospice 6 months or 5 months or 7 months before this almost arbitrary date. How do you start that conversation? How do you 6 months before death have someone face the reality that the rest of treatment is futile? You just can't do that. Another provision for hospice care is that each patient admitted to a hospice unit must have a primary caregiver. You have no idea how many people over the age of 65 live isolated lives. Sociologists have written about this problem. Nobody to take care of them. There is no full-time caregiver for many, many, many Americans who would be eligible for hospice. And the other snare in all of this is that if the patient goes into a hospice unit, he or she must from then on refuse any therapeutic care. So the patient must agree from now on in, no attempts at therapy will be tried. Well, there's therapy in this therapy. There's therapy in an attempt to cure disease, but there's therapy also in an attempt to relieve symptoms. The classic example is people with a deposit in a bone where a dose of X-ray will solve the pain problem, for example. But you can't do that. There have been, well, one very recent article in the New England Journal of Medicine, there have been several other articles indicating that for lung cancer patients, if you give therapeutic care and hospice care at the same time, the patients live a little longer, but that's not the issue. They live better. They live more comfortably, and they live in a state of much better equanimity than they had before. But if you have Medicare covering your hospice, you can't do that. So there are all of these problems. I talked about the physicians themselves. I wrote about a problem in How We Die that hasn't changed one bit as far as I can tell. The tremendous reluctance of many, many physicians to recommend that patients take on hospice care. I think 1/3 of Americans is not a lot. It sounds good when you compare it to 15 years ago, but it really isn't a lot, and it isn't enough. Doctors have different motivations for this. We tend, as many of you know, to be a little power hungry. We don't like to give up control of a patient. Some of us, I'm afraid, actually think in financial terms about control of a patient, but for most of us, it's something else. You don't want to turn a patient over to somebody else because you feel a sense of responsibility, but more importantly, you have this authority, and that's one of the reasons that there are physicians in every community in America who refuse to refer patients to hospice. You know, one of the nifty things about writing a book is you get to go on TV shows and meet all these people you've been surreptitiously watching in the afternoon, like Oprah Winfrey. So I was on the Oprah Winfrey show. It was a wonderful moment in my life, you know. I think I peaked at that moment, at least in the opinion of my children. And when we finished, it was a very emotional hour. And when we finished, you know, they do it live, they tape it, and then they show it again, but it's done live before a live audience. As soon as we finished, 2 women, perhaps in their 40s, came rushing up onto this little stage. Turned out they were both hospice nurses from Chicago, and their question to me is, what can we do to convince doctors to refer patients to hospice? And that hasn't changed very much at all. It really hasn't. So there we are. Now, I talked about advance directives. Patients can decide, if I have to be intubated, do I want to be intubated? If I'm on life-sustaining drugs without which I would die, do I want to keep that up? Well, that's fine, and you can go to your lawyer's office and write out your advance directives. You can do it when you come into the hospital. This has been known since the law was passed in 1992. 1/4 of Americans have taken advantage of it. That's all. Just 1/4 of Americans. So advance directives haven't helped an awful lot. Plus, how many times have I seen or heard of doctors who refuse to obey a patient's advance directives, who say, but this is a mistake. This person didn't understand what we can do now, and they continue the treatment. Or the other thing, the great Nancy from Dubuque story. You know, we write about families, the family this, the family that. The family's not a monolith. The family consists of a bunch of people, and they all have ideas. So mom's in the hospital, and she's got advance directives that she doesn't want to be on a respirator. And Joe, with whom she lives, her son Joe, says, okay, that's fine. Her daughter Mary, who lives in the next town, says, that's what we're going to do. That Mom and I talked about this. And just as they're about to stop the respirator, in flies Nancy from Dubuque. And she hasn't talked to her mother since 3 Christmases ago, and she's feeling dreadfully guilty. No, we have to do everything. So there go advance directives. So there are problems with every one of these bits of progress. What about ethics committees? They ought to be able to decide everything. When advance directives come up and a doctor says, I won't follow them, you go to the ethics committee, and they say, there it is, you've got to follow it. And since the doctors on such committees tend to have a lot of gray hair, people say, oh yes, wisdom is here, we'll do what they say. Well, I love talking to families who come to me, and because a lot do and say this happened or that happened. I said, well, did you ever go to the ethics committee? Or you can go to the ethics committee. Do you know what most of the time the response is? What's an ethics committee? Most people don't know hospitals have ethics committees. It's an amazing phenomenon. So that hasn't been much help either. So who consults them? Very often it's doctors who've made up their minds about something and just simply want a group of senior people to say, yes, this is the right thing to do. So they provide consent. Who are on these ethics committees? Do they have any training? Do they understand ethical dilemmas that have been written about in the bioethics literature? Do they know the precedents to the cases they're talking about? Who knows? Some hospitals, yes. Some hospitals, no. And then there's this other thing that has come up, which is hospital, government, and insurance regulations. This kind of thing didn't go on 15 years ago. Do you know that administrators make rounds on every patient in the hospital? They check every chart, and they do it to make sure that every insurance requirement has been filled out so the hospital gets its money. These are administrators who, as a colleague said to me one day when we were talking about this problem, they don't know who we are. They don't know who the doctors are. They don't know how doctors think about disease. They don't know how nurses think about disease. They don't know how ministers, pastoral care workers think about disease. They're just there trying to make sure patients are gotten out of the hospital as soon as possible. Then there's this other bugaboo called best practices, which you've read about in the newspapers. Well, I don't want to take all night talking about best practices, but they are derived in very questionable ways. Remember, each individual is a distinct human being with a distinct set of problems. The average Medicare patient, before he dies or she dies, will have 5 major diagnoses. If they have prostate cancer, they may have chronic lung disease, they may have congestive heart failure, they may have dementia, and best practices are derived by studying patients who have one disease so that nothing contaminates them. So they tend to be unrealistic. So many doctors have gotten involved in the business aspects of medicine that in self-defense they rush off and get MBAs. The chairman of my department at Yale has an MBA, right? His name is MD, MBA, and then FACS. His membership in the American College of Surgeons is behind his MBA. You go into a big group practice, and one of the doctors in the group has gotten an MBA. Doctors are busier than ever filling out insurance requirements. The average length of visit, as many have read, is between 7 and 12 minutes in a doctor's office. Very often the doctor doesn't look up from her computer because she's so busy entering the material. How can people understand sick patients? And then there are other rules and regulations, but first let me quote a very senior faculty member at a major university center in a city other than my own. Quote, much of the reconfiguration of healthcare has been hijacked by economic needs. He's a doctor so famous for writing, as a matter of fact, that everybody here would know his name if I told you what it is. Some years ago, a young woman named Libby Zion was admitted to the New York hospital by an intern at night, and she was in a delirium and a lot of other things were wrong with her, and they gave her some sedatives because she was being quite wild, and she never bothered to say she had taken cocaine very recently. In fact, she denied taking cocaine, and she died. And the hospital was accused of not properly supervising its residents. The residents worked too many hours, so in America now, residents, the people who really care for you at the bedside, can only work 80 hours a week.